So, our next topic is for bronchiectasis. We don't need to know too much details for the purpose of MRCP1. Few things we need to remember. What is bronchiectasis? As we all know, this is basically the permanent dilatation of bronchi due to chronic inflammation and recurrent infection. Now, although we are saying it is a permanent dilatation of bronchi, but all the signs and symptoms will be of bronchoconstriction. Although it is dilatation of bronchi, but signs and symptoms of will be bronchoconstriction. The reason being, as we can see, this is the normal bronchus. What happens in bronchiectasis? Bronchus will be dilated and rest of the lumen will be filled with excess mucus, and that is why we will get bronchoconstriction and all those signs, wheeze, uh, dyspnea, and all those things related to bronchoconstriction will be prominent. Talking about clinical features, someone with bronchiectasis will have persistent cough. They will produce copious amount of sputum daily, and then plus minus hemoptysis in advanced stage, and also based on what exactly is the cause causing this bronchiectasis, hemoptysis can be there, and recurrent chest infection. Obviously, there is no good movement of the mucus, and that can make a good medium for bacteria to grow. On examination, we will see crackles, wheeze, and we will also see clubbing. Obviously, as we all know, any disease which will cause chronic uh, desaturation over a longer period of time can cause clubbing. So, obviously, as we know, with bronchiectasis, there is some compromised ventilation and it can cause clubbing. Talking about the causes, bronchiectasis can be caused by infections such as tuberculosis, pertussis, pneumonia, measles, but this is important for MCQ purpose. The scenario will be a 50 to 70-year-old gentleman with the background of TB coming in with wheeze, worsening shortness of breath, and now he is taking some medication, a little bit immunocompromised, maybe methotrexate for rheumatoid arthritis, or maybe something for IBD, some malabsorption issue is there. What is the probable diagnosis? Bronchiectasis, likely. The other most important cause is cystic fibrosis. We all know cystic fibrosis is congenital disease which can cause thick secretions, and that can lead to ultimately bronchiectasis. Next is, just a moment. Yeah. Other causes secondary to cancer, foreign body, not important. Immunodeficient person, IgA, hypogammaglobulinemia. The other important is allergic bronchopulmonary aspergillosis, Carter-Jenner syndrome, Young syndrome. So we all know these are congenital diseases. Basically, Carter-Jenner is a triad of chronic sinusitis, bronchiectasis, and Young syndrome is also one of the cause. We don't need to go into the detail of these. For exam purpose, I would suggest to remember TB, cystic fibrosis, allergic bronchopulmonary aspergillosis, and Carter syndrome in MCQs. Next, one more thing here. We know the definition permanent dilatation. So obviously, uh, after definition, we need to remember this is associated with leukocyte antigen, human leukocyte antigen, DR1. So I remember it as bronchiectasis is the first doctor. Bronchiectasis is the first doctor. Enough to remember this. If someone is having previous multiple recurrent chest infections, or someone has chronic productive cough, they can ultimately develop bronchiectasis. Next, if someone is having recurrent chest infections and then copious amount of productive cough along with male infertility or malabsorption or childhood steatoria, then think of bronchiectasis secondary to cystic fibrosis. So this is another important cause as we were discussing here. Now, usually the associated comorbid conditions as far as joints are concerned, rheumatoid arthritis. For GI, it will be IBD, cystic fibrosis, plus minus, it can be gut there. Malabsorption and pancreatitis are linked to cystic fibrosis because of the thick secretions overall in the body. Talking about the investigations, we need to send sputum culture, and most common pathogen is Haemophilus influenza. So this is the important thing to remember. Chest x-ray will not be normal, but we need to do further investigations. Talking about chest x-ray, as we can see, all these lower zone areas are showing some bronchodilation, but they are not as normal as these areas as I marked on the screen. Next, so basically these are tram track appearance on the chest x-ray for bronchiectasis, and we will discuss these, but just to show you. So this is basically signet ring appearance on CT. Signet ring is basically every uh, bronchi and air tract, they are accompanied by the blood vessel, and usually the size of blood vessel and the air tract is equal. But what happens in bronchiectasis, the size of, so this is the blood vessel accompanying the air tract, so the size of air tract will be larger than the vessel. So if we see it from this side, so there will be this hollow pipe along with this vessel. So that appearance, we call it as signet ring appearance. We can see it is like a ring. Moving on, as we discussed here, CT is the gold standard, which will show signet ring appearance, where bronchi will be larger than their accompanying artery. Lack of tapering and bronchus will be visible within 1 centimeter of pleural space. What is this? Usually, the bronchi will gradually taper and they will stop right here more than 2 centimeter near the pleura. But what happens in bronchiectasis, because they are dilated, they will stay the same and they will reach almost within 1 centimeter of, as we can see here, here, of pleura. So this is what it is discussing here. Lack of tapering, bronchus will be visible. And once bronchiectasis is confirmed, we need to do then full blood count, IgE to rule out the cause further. IgE is basically to rule out allergic bronchopulmonary aspergillosis. And then we need to see if there is any aspergillus species. We need to do some immunoglobulin blood test, and then we can further rule out the cause if it is cystic fibrosis, if it is related to any other issue, if it is primary ciliary dyskinesia, or if it is antibodies against streptococcus pneumoniae to rule out the cause. But all this we don't need to remember. We can remember signaturing appearance on CT scan. We can remember sputum culture will show Haemophilus influenza, and then some associated diseases. Management, usually we don't need to remember, because the management is as of any bronchoconstriction, antibiotic if there is infection, oxygenation, some SABA short acting beta agonist, antibiotic, sputum sample. So this is very normal kind of management. The only thing we need to remember that is different is this airway clearance technique, ACT, or active cycle of breathing. So if I show you, yeah, active cycle of breathing technique. So in ACT, we do some physiotherapy, and we take 3 to 5 deep breaths followed by 2 to 3 huffs to clear the sputum, and then we will take a good breathe and control it, and then we cough to help us clear the excess mucus. So this is how we try to clear excess mucus. If mucus is not there, there is no bronchoconstriction, there is less favorable medium for bacteria or germs to grow, so we feel a bit more comfortable. If there is any infective exacerbation, we have discussed. Surgical management, we can do resection, we can do lung transplant, the criteria of which is person should be less than 65 and FEV1 should be severely impaired less than 30, or if there is any rapid deterioration. So this was all about bronchiectasis. 5 things we need to remember associated with HLA-DR1. How to remember bronchiectasis is the first doc. It is a permanent dilatation due to chronic inflammation and infection. And then we need to remember causes: someone with the background of TB, or someone who has male infertility, malabsorption, thick secretions, diabetes, obviously when there are thick secretions due to cystic fibrosis, the exocrine feature and endocrine feature of the pancreas will be impaired, which can cause diabetes. ABPA carcinogenesis syndrome. Talking about the MCQs, so this was the MCQ that came: someone having cough, productive, then wheeze, has background of rheumatoid arthritis, is taking some medication for it, and has some dilated bronchus. What is the most important organism which cause bronchiectasis? Haemophilus influenza. Another MCQ, which is the most common pathogen. Talking about another MCQ, if someone has non-cystic fibrotic bronchiectasis, then the most important management point is to do postural drainage with muscle training for long-term treatment. So that was all about bronchiectasis. Dilatation yet causing constriction, previous TB, cystic fibrosis, Most important, influenza. So now we know the MCQ pattern of bronchiectasis. Someone is immunocompromised either due to taking some medication, rheumatoid arthritis, CBD, previous TB. Someone is immunocompromised. Now they have productive cough for longer period of time. Two parameters. Next is X-ray or CT scan showing signet ring appearance or pram track appearance as here. So these are pram track appearance. 3. What is the diagnosis? Bronchiectasis. What is the most common pathogen? Haemophilus influenza. What is the most important step? Respiratory physiotherapy. Let's move on to the next topic.